My name is Vinay Badhwar. I'm a heart surgeon here at the WVU Heart and Vascular Institute, and today we're going to talk about robotic cardiac surgery. So there are many different ways of doing heart surgery. That's either through an incision through the front, and the days from the Adam's apple, the belly button, and all that kind of stuff from the way past, we don't even do that at all here. Even through the front, it's a very appropriate and excellent a way of doing open heart surgery that has minimal trauma with a small skin incision in the front. But we do have to open the breastbone to get inside the heart to do certain operations. Now, for certain ailments, people can be candidates to have this done robotically. Not everyone is a candidate for robotic surgery. For example, if you need multiple different operations that include a bypass operation or coronary artery bypass grafting, those are often best done through the front, which are done every day here at the WVU Heart and Vascular Institute, and patients do extremely well. Now, when there are certain ailments, such as valvular disease or the need for treating atrial fibrillation, often we approach those situations robotically. The candidates for robotic heart surgery are those that have usually not had previous heart surgery before or previous lung surgery on the right side, and those that don't have major ailments of the vascular system. To determine if people are a candidate for robotic surgery, not only we look at their past history, their actual medical issues, but also we review their heart catheterization, which is a diagnostic test that we check the coronary arteries for blockages, and a special CAT scan that we do from essentially the chin to the knees to look at the entire vascular system, but also we look in 3 dimensions around the heart and chest cavity to make sure that we can take care of this patient robotically. Once those tests are done, your surgeon will discuss the likelihood of being able to do this robotically. Here at the WVU Heart and Vascular Institute, we have become one of the world leaders in robotic surgery. In fact, not only patients from around the world, but in fact, surgeons from around the world come here regularly to learn some of the techniques we've developed here. Now, that said, it's a very personal relationship we have with every single patient to make sure that they're cared for just like we care for any of our own loved ones, to make sure that we do this safely. The safety of robotic surgery is paramount to us, and so we make sure we do this very precisely every single time. So a common question people ask is, does the robot do the operation or do you do the operation, doctor? So no, the surgeons do the operation. The robot is just an instrument. And the instrument is used just to facilitate the smallest of incisions and essentially next to zero trauma. And so one surgeon sits at the console, and that surgeon is manipulating the actual robotic instruments, the multiple arms, all simultaneously. And the surgeon at the bedside helps with direct care as needed and robotic instrument exchanges and things of that nature. That team approach is essential for the expediency, the speed, and the elegance of how the robot operations work. How do we do robotic surgery? So that's done, instead of through the front, we go through the 4th rib space on the side, basically under the armpit to the right. It's all on the right side. Now, people often ask, well, why are you on the right side when the heart's on the left side? Well, the reason for that is that provides direct access to all of the valves of the heart and the chambers of the heart that we commonly perform robotic surgery on. We access it from the right side through a small incision about anywhere from 3 centimeters to 4 centimeters. And we don't break any ribs. We just go through what's called the oblique muscle and the skin, not the pectoralis muscle, which is the large muscle here, and not the latissimus dorsi muscle, which is the muscle of the back that I'm sure people have recognized. Because it's really minimally traumatic, we put a few little ports also, about the size of one's pinky nail, 3 to 4 on the chest around the working incision, to pass instruments, the robotic arms, into the chest. Of course, everybody's asleep. We make a small little nick in the groin and a small little nick in the neck where we place tubes to take over the work of the heart and lungs. Then we go inside the heart at the time of the heart operation using the robotic technology after we put the heart to sleep, like we do in every other heart operation. And then using the high fidelity visual optics of the robotic camera and the telemanipulation of the wrist actions of the robot, we're able to achieve really excellent outcomes for patients for valvular reconstruction or repair, valvular replacement when needed, and then surgical treatment of atrial fibrillation. In our center, we've helped pioneer a few different things, not only robotic mitral valve repair, which has been the most common operation that we do, but also aortic valve repair or replacement, which is something we've developed here, but also surgical treatment of atrial fibrillation. All of those types of treatments, and sometimes in combination, can actually be done robotically. One thing to note, to remember, that when you come for robotic surgery, we give a small little injection on the back, our anesthesiologists do for those that are candidates, to just numb the nerves a little bit to minimize pain almost completely for many patients. We put a little catheter in the left arm and a little catheter in the neck. That'll be done after one's asleep. So after surgery, the recovery is quite quick. In fact, the vast majority of patients with robotic surgery will come off the ventilator in the operating room. Just ask your anesthesiologist if you're a candidate for that approach, and that helps expedite recovery. In fact, many patients are out talking and almost immediately can meet with their family members and loved ones. After the first 24 hours, usually our patients are walking and breathing on their own, and the total length of stay commonly for certain patients, particularly just one valve or one therapy, are usually about 3 days. Some can go home in 2 days. Otherwise, for those that have multiple types of operations or an atrial fibrillation operation, the length of stay is about 4 to 5 days. When one goes home, just no driving for about 3 weeks just to protect this. It's going to be relatively common sense, unlike the chest incision. And just you can sleep in your own bed, do your own personal hygiene. Just no lifting, particularly with the right arm. Pulling down will hurt a little bit, pushing up will hurt a little bit, but the left arm is usually okay. And after your recovery, usually about 3 weeks or so, we let people drive, and many people actually return to work.